Okay, good evening, everybody. Welcome to today's program brought to you by the Orthopaedic Research and Education Foundation through OrthoTV. And today we have Dr. Arvind Gupta, our arthroscopic sports and arthroscopic surgeon today, uh, who's going to talk to us. And all of you know Arvind by now because he's been giving multiple talks on these sessions. And without much ado, I would hand it over to Arvind to continue with his talk or start his talk. Thank you.
Thank you very much, sir, for the opportunity. So I'll start the sharing of this without wasting the time. And so rotator cuff tear is very common in elderly population. At the same time, the surgery nowadays also going on to help in healing of the tendon. And most of the time, this cuff repair needs to be anatomical without any tension. And this is the ideal situation. And in the post-op period, this tendon gets healed with the bone by enthesis regeneration. But almost in 20 to 40% of the cases, this rotator cuff get healed with the reactive scar, and there is failure of mineralization of the fibrous cartilage. So this reactive scar is not the ideal tissue of the rotator cuff. So because of this, such type of healing, the function as well as the pain persists for very long time. Even lot of patients don't get completely free of the pain even after the surgery. At the same time, function don't get returned back to the normal. So re-tear rate, the literature says almost up to 10 to 90% of the cases. Because of that, surgeon started doing biological as well as a structural augmentation of the rotator cuff repair surgery. And this biological augmentation supposed to improve the biological condition of the healing environment, and it having lot of things started from the growth factor, that is PRP, cell-based therapy, stem cells is very commonly researched in this field. Then the bioinductive implant. Nowadays there is a patch that enhance the process of healing. This patch don't give the mechanical support, this give only the biological healing to the repair tendon. And this biological augmentation, PRP, is the most studied adjuvant for the rotator cuff tear and repair. And also we all know the PRP has been categorized into the 4 types depending upon the amount of leukocytes as well as the platelets. At the same time, a researcher has found that it's the concentration of platelets, different concentration of platelets needs for healing of different tissue. So for rotator cuff, it is almost more than 5 billion platelets needed for its good healing, as literature says. And the meta-analysis of the use of platelets, it says there is no impact on the clinical outcome. But there is subgroup analysis says PRP decreases the re-tear rate. But functionally, there is no the clinical outcome in terms of all the spores around the shoulder after surgery. Another meta-analysis, it says there is significant higher healing rate in the small and the medium size rotator cuff tear. The systemic review of meta-analysis say there is no clinical benefits in terms of functional outcome. So author concluded in this systemic review and meta-analysis that they can neither promote nor discourage the use of platelets-rich plasma in rotator cuff surgery. So overall consensus says there is no benefit. However, there is advantageous in terms of prevention of re-tear. Then the cell-based therapy is the stem cells, which is the very commonly research for this rotator cuff repair. And it says it's promote the cell to differentiate into the tenocytes. It's having different component like mesenchymal stem cells, culture mesenchymal stem cells, bone marrow aspirate concentrate, that is BMAC. Then there is bone marrow stimulation, adipose derived stem cells, the umbilical cord blood derived stem cells, and the subacromial bursa derived cells. Initially, we used to take out all the bursa from the subacromial space, but nowadays research says this subacromial bursa is having a lot of growth factor and it helps in healing of the rotator cuff. So about the mesenchymal stem cells, it's enhanced the healing potential but failed to demonstrate the benefit. That is the meta-analysis. Then the BMAC, it's limited scientific evidence which does not allow for a strong conclusion for the use of BMAC in the rotator cuff surgery. And then the next is the bone marrow stimulation technique. That is one of my favorite technique at the time of rotator cuff repair. So you just do the multiple puncture in the footprint of the cuff with the K-wire or microfracture all. So there will be multiple vents into the footprint, and this leads to the formation of clot under surface of the repair rotator cuff. And this technique was demonstrated by Snyder. There is no extra cost added to it. There is easy to do. There is no any side effect of this procedure. And this is one of my favorite things for augmentation of the rotator cuff. This is like this. And finally, you do repair over that. And if you see the systemic review and meta-analysis about the use of this, the marrow stimulation technique, this says it may have positive impact on the healing and repair rate, although the available evidence is limited and more research is needed. And another recent one, it says level 1 evidence in the literature did not support the bone marrow stimulation as a modality to improve the re-tear rate or clinical outcome after arthroscopic rotator cuff repair. Then the adipose-derived cells, stem cells, again, no functional outcome measures till now. But MRI study says the structural integrity of the tendon in which adipose-derived stem cells was used, significant better. Similarly, with the umbilical blood-derived mesenchymal stem cell, most of the study in animal model again needs to be the more further data for future study. Then the some patch nowadays available in the market, which improve the biology of the healing of rotator cuff repair. Like this patch that is one of the company now available in India, that is Regenerated. After the repair of the cuff, you just place that patch over that and you fix with the anchor that is provided by the company. The recent meta-analysis in 2024 November last year only, it say that it's the safe augmentation. Patients are likely to experience significant subjective improvement in range of motion as well as the tendon thickness. They demonstrated on the basis of MRI, and it says in which the bioinductive patch was used having better thickness of healed rotator cuff. And this re-tear rate also may be risk of this re-tear rate is less with this, and overall complication is almost similar. So after this, all these, the biological augmentation, there is a structural augmentation for rotator cuff also. So it's basically provide the mechanical support as well as reinforce the repair with the patch and the graft. There is a lot of patch that provide the structural support also. One side it was the biological support. Nowadays there is patch for the structural support also. So it's help in the healing and also decreases the tension of the repair this cuff. This may be allograft, so graft from the human donor. It's also available in India. That is dermal allograft, and there is tendon allograft. And there is autograft also. Autograft may be this lot of tendon, latissimus dorsi, the lower trapezius tendon. Nowadays, there is long head of biceps tendon is used as for structural augmentation. Then there is a lot of synthetic material and the biocomposite scaffold also. So in allograft, the Arthres company is having Orthoflex that is available in India. And also there is the jacket graft by the Right Medical that is also available. So this help in the structural support of this cuff tear. Suppose the torn cuff is not repair fully, it's partial repair only. So such type of this graft can be placed over that and this gives the structural support. At the same time, the tendon allograft like lower trapezius or latissimus dorsi tendon can be used from the cadaver for this use. So this is the biceps tendon autograft that is used. So this was very massive cuff tear starting from the subscap to complete supra, infra, and teres malus. There is hardly any cuff was attached over the humeral head. Humeral head was completely free of that. You can see here, it's completely free. There was no cuff tear. And also it was retracted almost beyond the level of glenoidea. In such type of cases, this long head of the biceps is rotting. It's placed in between almost in the supra and the infraspinatus, and that get repaired, and over that all the tendon get repaired over that. So this decreases, this long head of tendon decreases the tension over the repair cuff in itself, it taking the tension of this construct. So in such type of massive retracted cuff, nowadays it's very common long head of biceps tendon use. And this is the recent literature about this, very recent one. And it says it reduces the visual analog score, improve the abduction as well as the external rotation in the post-op period. At the same time, there is clinical and functional also outcome also get improved. But again, needs for further study. And then another tendon transfer nowadays it's getting very popularity because of lower trapezius tendon transfer. Again, this was very massive cuff tear in which it was retracted almost beyond the level of the glenoid. And this was after the repair. You can see there is partial repair of the tissue was here. So in such type of cases, lower trapezius tendon can be taken. This is in the line of infraspinatus. And again, orthoscopic assisted the fixation of this lower trapezius can be done. So this give the strength to the repair tissue in which it was only partially it was able to achieve the repair of this. And this is the lower trapezius tendon transfer. It is very bulky. This bulk can be made with the help of either this a hamstring or peroneus longus. And this can be suture and then finally it get fixed to the its anatomical position of the infraspinatus. Again, recent literature in the May 2025, it says the lower trapezius transfer is a reliable option for rotator cuff tear. This offers the significant improvement in the clinical as well as the functional outcome. It is particularly effective in restoration of the external rotation. Next is this biocomposite scaffold. Again, this is scaffold is made of the collagen, as well as it is having this bio-reabsorbable polymer microfilament. And this is for the initial strength, and that is lactic and lactic acid. And this collagen scaffold gives the biology for the healing. So this help in the load sharing as well as healing of the tissue. So this after the repair of this supraspinatus or cuff tissue, you just place this patch over that. Again, it is available in India, and this is how it's you suture it there. So future direction and the consideration in the biological as well as the structural augmentation is the selection should be optimal. That is the further research is needed to develop the standardized protocol and clear the guideline which augmentation technique is best suited for a specific patient characteristic and the tear pattern. And there should be combined approach, both biological as well as a structural uh, for the better this result of healing of the rotator cuff. And this should be this represent in the promising area of the research. Thank you.
Thank you very much, Arvind.
Thank you,
I'm
sir.
sure there'll be some questions, so we should open it to the participants.
Sir, while we are waiting for questions, sir, one thing, sir, about the patch is because of its cost. So, how you select the patient and
Yeah,
what you consider was.
so absolutely right. Cost is the main factor for all these paths. So most of the time, my approach is nowadays for long head of the biceps, because most of the time patient is post 60, 65, 70. Anyway, this long head of biceps is no much more used in such type of patient. So and also along with the massive cuff, this long head of biceps also get dislocated from their groove. So this gives the structural augmentation most of the time. And so this is my first preference. And second preference is the lower trapezius tendon, because this is in the line of infraspinatus. You only have to increase the length of this lower trapezius tendon with the help of either peroneus longus or semi-T. And this gives very good thickness, and this coverage of this with the help of this tendon is very good. And also there is a lot of literature nowadays coming in favor of use of lower trapezius. Regarding the patch, definitely its price is the important factor, almost 4 to 5 lakhs. This is costly. So mostly the insured patient get used with this. And also I use only in the massive cuff only, not for the mild to moderate type of cases. We need tendon quality is good, and if you fix in a good way without any tension, with good coverage of and this the footprint, and if you follow all the principle of repair of the rotator cuff, and most of the time result is very good. So my indication for the massive retracted cuff tear most of the time.
What about, there's been a fair amount of excitement over the use of this balloon cuff plasty, where you just have this, I think Stryker have got it and others
Yes.
have got it, where you just inject this sort of balloon which gets injected with saline and acts as a buffer between the
Spacer, yeah.
acromion, spacer between the acromion and the head of the, so it stops the head from going up, which is one of the problems that you get with rotator cuff tears.
Yes, sir. So balloon, this spacer is used mostly for those who cannot afford the surgery in terms of medical problem. Very comorbid patient, and patient is lot of pain around the shoulder because of massive cuff tear with almost superior migration of the humeral head. So this can be done under local anesthesia, just the placement of the balloon and the inflation. Only problem with this balloon spacer is it's work only for 1 to 1.5 years only, not more than that. So that is the one of the problems.
Yeah. So what happens after the year?
So this get deflated.
Okay.
Or many a time
So
this gets lost from its place.
So again, the next surgery we can do balloon, sir.
So
Right.
basically, again, those
So
who
again, the balloons are not cheap. It's not.
yeah,
It's
it's
not as
not cheap. It's almost 2.5 lakhs.
So, sir, because you have done, I think about 2 to 3 years back, also I have seen you have done that PET, sir. I have assisted you. So, what is the functional outcome? Is it same, sir, or is it improved with this patch?
With the patch, definitely in our patient also, we have used in 5 cases till now. So none of those having re-tear till now. Post-op period, recovery of rotator cuff is most of the time 5 to 6 months. They have little bit early recovery only, what I can say, considering that. So in 5 cases, all these 5 cases, they are doing good. They have returned to their pre-injury level, and the pain is not there. So many a time, even this cuff get healed, lot of patient is having pain. So all these 5 patients don't have pain till now. And surprisingly, all were massive cuff tear. They all have retracted till the level of glenoid. The good thing was that I was able to repair all the cuff to its normal position. All was double row repair. So all cuff came to its normal footprint without any tension. And over that, I put that patch.
So it's interesting because I can't remember. It was about 6, 7 years ago. I was in Pune where this very senior surgeon, who was one of the pioneers of cuff repairs, what's his name, Larry something, from Texas.
Okay. Helix.
No, no, it was,
Texas, Stephen Burkhardt. Texas.
no, not Bukhard. It was someone else.
San Antino.
No, it was so older chap.
Snyder.
Snyder.
Yeah, Snyder, he used to come.
So he had more or less given up doing rotator cuff repairs surgically, saying that physiotherapy and exercise and all actually gives you as good or better a result rather than all this surgery which ends up with problems. So what is your take on that?
Yeah, definitely. A lot of this rotator cuff tear does good with this good physiotherapy
Yeah.
with the strengthening of deltoid muscles. And the problem started when there is any superior migration of the humeral head or there is progression of the cuff. These two things has to be monitored, even though if all these patients get managed conservatively. So if patient gain their abduction or rotation strength with the physio, so that is the good thing, because lot of surgeons, those who are doing cuff repair for massive cuff tear, not able to repair it completely. It's partial repair only.
Yeah.
So that partial repair is like cuff tear. But in the post-op period, they advocate for very serious exercise for the shoulder, building up all the muscle around the shoulder. And all literature says it's good. So most of the time, cuff tear, first time until unless it's not traumatic one. If it is traumatic
it's a
one,
clear-cut traumatic tear, that's a different situation.
repair. And if it is degenerative one, then the recommendation say its first trial should be physiotherapy, even injection can be tried in such type of cases. And if it fails, then only they should be advocated for.
I think it was Larry Schneider only.
Yeah, yes. He used to come to India.
Sir, if just one question, sir, you has mentioned when it like proximal migration of the head. So whenever there is a rotator cuff tear, sir, usually it gets migrated. So
over time.
Over the time.
Okay, sir.
So basically, this cuff is having 4 types of attachment. So if you see here, so this is the supraspinatus, this is subscap, this is infraspinatus.
We are not able to see, sir. We are not able to see, sir.
Yeah. Now.
Yeah.
So this supraspinatus act as a depressor or central stabilizer of your humeral head. So once this get tear, so this is not a major concern, because the posterior part of infraspinatus and teres minor and anterior part of subscap keep in its position. But once this cable get disturbed, So this is infra and teres minor and or subscap. Then there is balance of this force get disturbed and this humeral head get started migrating superior. So most of the time this superior migration associated with the massive cuff tear. And once this has started, it means there is this acromion and humeral head will comes to the contact, and that leads to development of rotator cuff arthropathy. So that is the major things all arthroscopy surgeon wants to prevent. So for traumatic one, they advocate for immediate surgery. For degenerative one, because this cuff degeneration is very slow and one day it get torn. Meanwhile, many a time this shoulder get compensated with the deltoid muscle all around the shoulder. So you and everyone, we have seen that even though if cuff is there, but patient is able to lift the shoulder. So that is the compensated shoulder. So such type of compensated shoulder can be managed with conservative treatment. There is no problem. Because in that case, this the muscle around the humeral head is working very good. This will prevent the superior migration of humeral head. But lot of shoulder is decompensated. Patient is not able to lift the humeral head, abduct, cannot able to abduct, or cannot able to rotate the. In such type of cases, there is very high chances of superior migration of the humeral. That leads to a degeneration of the joint. That leads to rotator cuff arthropathy, and that finally treatment is the reverse shoulder arthroplasty.
Right.
So, sir, whenever you are repairing, sir, you like more focused on infraspinatus than supraspinatus, right, sir?
No, so basically, most of the time it's tear of the supraspinatus. It's start with the supraspinatus. Then it slowly progress. Supraspinatus, infraspinatus, teres minor, slowly progress. So repair should be, it's on the footprint ideally, and it should be tension free. But in case if you don't able to bring the supraspinatus here, you can do with the single row just lateral to the articular surface. Even up to 3 millimeter, you can medialize the repair part. The aim should be tension free. There should not be tension over the cup. So what this long head of biceps does, from here you bring this long head of biceps here, so that this act as a depressor of your humeral head. So for a massive cuff tear, even if get torn in the future, at least this act as a depressor of humeral head. It don't prevent the superior migration of your humeral head. So this is the main reason of pain in case of massive cuff tear in which the humeral head gets superior.
So any questions from any of the DNB students, etc.? Doesn't look like it. I think.
Yes.
Right. So if there are no further questions, thank you very much, Arvind.
Thank you, sir.
And,
Thank you very much.
Thank you very much. That was useful.
Thank you very much, sir. It was great, sir. Great learning.
Okay. Right. Bye.
Thanks.
So,
Thank you, sir.
वो आज उसका सब हो गया ना? अच्छा, sorry. Can they stop it
Yeah.
from going live?
Yes,
Stop it.
just a minute, sir. Just I'll need to ask Maharshi. I'll just call him, sir.
What time are we starting the other meeting? 8:45.
Yes, sir. 8:45. Actually, he is not picking up, sir. Maybe that was done,
Doesn't
sir.
matter.
I have seen it. Yeah.
Okay.
I've seen it.
Right.
Thank you. Thank you very much, sir.
Okay.
So,